Hey everyone, welcome back to the third of our four-part webinar series on the new quality payment program, MACRA. I'm Joe Young, CEO of Global Data Systems, and I just wanted to thank everyone for attending today. For those of you who don't know us, we're an IT and security consulting organization. We're extremely focused on the healthcare market. We work with a lot of practices of all different sizes to make sure their security and compliance posture meets not only their needs but the regulatory requirements they're faced with. So as I said, this is the third in a four-part series. In part one, we provided an overview of the MACRA and MIPS program. And last week, in part two, we did a deep dive on the MIPS quality measures. And today, we will be providing a deep dive on the ACI measures. I wanted to remind everyone that we are recording the webinar series. So at each webinar, we will be providing links to the recording. So anytime you want to review the information we're providing you, you can do so at your leisure. So now I'd like to welcome Jen Monahan. She's a partner and senior consultant at Health One Technologies. Jen, as many of you know, has tremendous knowledge and experience on the clinical, workflow, and compliance issues that many of you deal with on a daily basis. She's a sought-after consultant in the healthcare community, and we're very lucky to have her here today to provide you with this important information that affects us all. So with that, we have a lot of information to get to, so take it away, Jen.
Thank you, Joe, and welcome, everybody. Welcome back for those that have attended previously, and for those it's the first time, welcome. Today, as Joe said, you did a great introduction. We are going to be talking about the Advancing Care Information Measures, otherwise known as your meaningful use previously. What we're going to do today is I'm going to do a quick recap of some of the information we've covered in previous webinars. We're going to dive into the Advancing Care Information component. We're going to talk just an overview of what it is in general, the requirements associated with it, exceptions and hardships. We're going to talk again a little bit about individual and group reporting, the mechanisms that we use to submit the ACI measures at the end of the performance period, how it's going to be scored, which includes base and performance points, and then where we're going to start in the process, so including selecting your measures and things you might need to consider with your EHR system. So just to recap quickly what we've covered so far, I do like to keep these webinars to 30 minutes or less. It just helps, I think, everybody's schedule out. But I thought I would just quickly recap what we've talked about in the first two webinars. You are more than welcome to go view them. They are on either Global Data Systems or Health One's YouTube channels, so you can watch them there, or you can also send us an email to get a link. What we talked about in the first one was just an overview of the program. What is MACRA, some dates associated with it, the program review as a whole for MIPS, the MIPS component of it, who's eligible to participate, payment adjustments, reporting periods, what to do to avoid penalties, how to maximize your incentives, and where to start. So that is all covered in the first webinar that we did a few weeks ago. In the second webinar, which was last week, we focused on the quality component of MIPS. So we did a quick review of the MACRA program, and then we talked about, in particular, the quality measures, and really did a deeper review of the descriptions, the requirements, again, exceptions, individual and group reporting, how to submit the measures, how they're going to be scored, and where to start the process. So same sort of concept that we're doing today with the ACI component we did last week with the quality component. So I would encourage you, if you have not had an opportunity to participate in those webinars, that you go and take a look at the videos. There's a lot of important information there about the MIPS program as a whole. Okay, so for today, we are talking about advancing care information. We're going to start, I'm just going to give you guys a quick overview of what this component is going to represent and some key information that I'm pulling out of the final rule. I do want to just say that the final rule for the MACRA program as a whole is still open to a comment period, so there is some possibility that some of the things that I'm presenting might have a slight change to them. I think it'll be minimal, but the information that you're getting should be a good representation of what we're going to see at the end of the product. So the advancing care information represents 25% of your total MIPS score. So if you remember from last week's webinar, we had talked about quality representing 60%. The next biggest component is the advancing care information. It represents 25% of the score. And it is taking the place of the EHR incentive program, otherwise known as meaningful use. So what's going to happen is, as of December 31st of 2018, the payment adjustments sunset under the meaningful use program. And what that means is that we're not doing meaningful use in 2017, but the payment adjustments will happen in that time period. Because remember, with the incentive programs, a lot of the payments happen 2 years after the performance period. So as of the end of 2018, the meaningful use program goes away as a whole. The exception to that is the Medicaid portion of this. And I didn't put a detailed slide in about this. If I have people that are reporting to Medicaid meaningful use, you will continue to do that. It is going to be through 2021, so the Medicaid payment portion will remain intact. So the ACI component of MIPS combines the updates to the 2015 EHR modified stage 2 and stage 3 requirements. So they took those requirements and they made some changes and modifications, and that's how they came up with the MIPS component of ACI. And then the CMS is using the ACI. There's a lot of discussion about this in the final rule to continue driving forward EHR technology. So they felt like it was important, as we talk about quality of care and improving quality, and since MACRA is a quality payment system, that we really continue using our EHR technologies to work toward that as well. So that's why they've kept the ACI component in place. And you'll notice that there are, as we go through this, there are things that they've tried to fold in. So as we do improvement activities, for instance, if we are using our EHR technologies, we can get some bonus points. So they really are trying to blend all of the three components together as much as possible. But they didn't want to lose the focus on the EHR technology, so that's why this component is here. And then for 2017, there are a few things one important thing that we really need to talk about is the certification of your EHR. And that's going to drive what measure set you use. So there's a 2014 certified technology and 2015 certified technology. The majority of people are currently on a 2014 certified technology. And that is going to use, there's a set of measures called 2017 ACI transition measures. And that's what the measure set that you'll use as you go through this process. Sometime in 2017, I suspect that a lot of EHR vendors will be releasing new technology. And if that's the case, we'll then start using the second set of objectives that is available for the MIPS program. It looks like, from what I am gathering in the market right now, that not a lot of vendors have that certification for the 2015 product. Requirements of the program. So 2017, as we reviewed in the overview of MACRA, the performance period is a minimum of 90 days. CMS is encouraging a full year of reporting, but they have recognized that, just like they have in the program as a whole, they basically released this information in November, didn't give people a lot of time to plan and put things in place. So they are saying it's a minimum of 90 days. They are encouraging you to do a full year of reporting, and a lot of the incentives have a higher return if we're doing a full year reporting. It also looks like they're proposing that 2018 may be a 90-day reporting period under the ACI component because of the software versions that are going to be changing in the market. The program has a total of 5 base measures that we have to meet to participate in the ACI component. We'll talk about a few discussions later in the webinar, but if those base measures are not met, you're going to get a 0. So that's an important important fact, and you'll see that as I go through the webinar. I mentioned that several times because that's very, very important. There's additional measures as well, and also performance associated with them that are optional. So you could just do the base measures and get a 50% in the ACI, or you can work toward optional measures as well and bring that performance up. There's several exceptions and hardships, and this gets a little complicated. I've done my best to kind of break this down and put it out there for people. So a lot of people will remember, if you attested to meaningful use, there were exclusions that you could do. So for instance, if you were a provider that wrote fewer than 100 prescriptions in a reporting period, you could exclude from that measure. You could actually claim an exclusion. CMS is not allowing us to claim an exclusion for the measure, but a 0 is acceptable. So if you aren't doing any of those, as long as you're reporting that you were e-prescribing, if you had a 0, that's fine, that's acceptable. At least you were reporting it at that point. So you won't claim an exclusion, but they're basically not penalizing you for a performance in that. There's also some rules around hospital-based clinicians, and what's going to happen is they're automatically going to be excluded from participating in the ACI, and the weight of the component, so if I remember, it was 60% quality, 25% ACI, and 15% for the improvement activities. What they'll do is they're going to change the weight of that for those hospital-based eligible clinicians, and we'll look at that in a slide coming up. But the ACI component will basically just be redistributed out to the quality and improvement activities. So a hospital-based clinician is defined as somebody who does 75% of their services either inpatient, emergency room, or a campus outpatient hospital. So those are based on the place of service codes that you use on your claims. What I understand CMS is going to do is they're going to use a reporting period prior to your performance period. So I gave an example down here. So for 2017, they're going to look at claims from September 1st, 2015 through August 31st, 2016. In those claims, if 75% of an EP's visits or charges have been billed at a place of service code of 21, 22, or 23, then they're going to automatically exclude you from the ACI component, and they'll reweight your activities to the other 2 focuses. If for some reason you choose to not take that exclusion, not sure why you would do that, but if you choose to not take that exclusion, then you are responsible for submitting the ACI measures. And if you fail the base measures, you will get a 0 on that component. So I would encourage you that if you are identified as a hospital-based clinician and you know it's not possible for you to do the ACI, that you just take that exclusion. There were other hardships that were available under meaningful use. Some of you may have remembered if you had insufficient internet connectivity, if there were circumstances beyond your control. They've added a couple of new ones here. Lack of control over the availability of your certified EHR technology, and lack of face-to-face patient interaction. The way the hardship's going to work, in previous years under meaningful use, you had to file a hardship by, it was usually July, sometime in July, you had to file a hardship. And they're actually extending that, so the hardship won't have to be filed until we're submitting our data. At that point in time, if you are somebody that falls into the category of insufficient internet connectivity, extreme circumstances, you have a massive fire or flood or something like that in your business, then you would file that hardship prior to March 31st of 2018. I don't know what that application is going to look like yet. Typically in the past, it has just been something that you can download from the CMS website, complete, and then send it in. That has not been defined, but I would assume it's going to be a very similar process. I wanted to call out the lack of control over the availability of the EHR and just talk about that one a little bit. This refers to a provider that may be participating or doing services for a group, but isn't actually part of that group, so kind of like a contractor. If I have a contracted physician that comes in and does a portion of their visits in my group, or I have a nurse anesthetist who's doing something on a contracting basis, those people don't really have control. They have no decision-making powers in your group around the certified technology. So they're able to file a hardship because they don't really belong to your group. So that's what the lack of control over the availability of the CHRC, the certified technology, means. And then the lack of face-to-face actually does not require a hardship because they believe it's going to fall under the hospital-based eligible clinician. So anybody that is a pathologist or radiologist that's just reading tests and doing tests, more than likely they will fall under the hospital-based provider and not have to file a hardship. This one was interesting to me. So this is an exception just for 2017. In the past, nurse practitioners, PAs, CRNAs, they didn't have to do meaningful use. So what they're doing is they're basically giving us a transition period. And they're saying that if you are one of these types of providers and you don't feel like you can do the ACI component, they will reweight your score accordingly. So basically you just would not attest to the ACI, you would skip that portion, and then they're going to take your score, and you can see in the table below what's going to happen is normally quality gets 60, improvement activities 15, ACI 25. They're going to break that out. 85% will be weighted to quality, and then 15% to improvement activities. That's an important thing to know, and groups will have to make some good decisions about that. Having 85% of the score weighted to quality is a big bucket, so you'd have to make sure that you're really putting a lot of focus in on the quality if that's the case. So this is something that I wanted to make sure people are aware of, because a lot of groups didn't really take into account their PAs or nurse practitioners when they were doing meaningful use. So it's something that we're going to have to just pay attention to as you're looking at your organization and those types of other providers, mid-level providers, we might have to make different decisions for. So again, individual and group reporting, I know we talked about this in the quality program last webinar, but again, it's the same case for the ACI measures. So if we're reporting as an individual, then each provider is scored based on their own measures. Payments adjustments are done on an individual basis. Measure selections can be different. Individual providers have their own performance to be accountable for, basically. One thing that I want to just point out is that if you're doing individual or group reporting, you have to do that through all of the components, so quality, ACI, and improvement activities. It can't be that you do individual for ACI and group for quality. It doesn't work that way. So basically, if your organization decides you're reporting as individuals, you'll report as individuals across the entire 3 programs. Same thing as group. So that's an important thing to kind of keep in mind. Group reporting was not previously available for meaningful use. So that meant that each and every provider we had to go and do an attestation for. So some of you may remember, if you have a larger group or even smaller groups, there's a tedious process involved in the attestation. So each and every provider, we had to go and fill in all of the measures and what their numerators and denominators were, and if they met that. So they've changed that under ACI, And we can now do group attestations or group reporting for this. What happens is they take the scores across the organization and they're aggregated. So your numerators and denominators basically are just put together, and an average is taken, and that's what you're going to attest to. So whatever you submit is the group's ACI score. That's how that's going to work, versus the individual's ACI score. And again, it's just some things to consider. The measure selection would need to be standard. You know, the administrative burden might be a little bit lower because you may be reporting just for the group. That overall attestation process will be less. However, you know, you're still going to want to monitor performance for each provider because the aggregate is the average. So you don't want to have a few providers that might be performing lower, impacting the higher providers. Mechanisms for submitting the ACI information. So again, in the past, we just had a manual attestation window that we had to go to. We had to go to CMS. We had to do a process where we went in and filled in each provider. There were a few software tools out there that allowed you to kind of batch attest, but for the most part, everybody went and manually did this process. So there's going to be a few other options available. The QCDRs, which are the clinical data registries, which we talked about in the quality program. Certified registries, which previously had just submitted PQRS data, are now supposed to be able to submit the ACI data as well. There's still going to be a manual attestation process, and then there is a CMS web interface also that can be used. So in the end of 2017, when we do that reporting process, the ACI components will need to be reported in some way. And one of these is how you will actually support or submit those measures. Now we're going to talk about the scoring of the measures. So again, 25% of your total MIPS score is ACI, unless you meet one of those exceptions we talked about earlier. They're going to have this broken into the most important component is the base measure, and that's going to equal 50% of your score. The reason CMS did this is they wanted to make it not an all or nothing. They wanted to provide flexibility for people, but they also wanted to make sure that people were still engaged in the technology product or program. So they made it so that you have to do certain things in order to get the 50 percentage points. I think they're fairly straightforward, and they've made it a pretty simple process, but if you want to get those 50 points, you have to do these things. The remainder of the points are made up from a performance process. So not only are you doing it, but you're doing it well, and that's how you get the extra 50 percentage points. And then there's a few things that will give us some bonus points. So the base measures, I'll review what these are, but every measure is required, as I said, and you must have either a 1 in the numerator and denominator or a yes in the yes-no measure. So if you don't report these, you get a 0 in the ACI component. And the base score, if you get a 0 in the base score, you also can't get performance points or bonus points or anything like that. So if you don't pass the base, you get a 0. There's a lot of focus in the final rule on privacy and security, and that is one of the elements that is required in the base score. The first thing right off the bat they say is a security risk analysis. Then they talk about e-prescribing, health information exchange, and providing patient access. So those are the requirements that we need to do in order to meet our base score. If you are in the 2017 transitional measures, I think that's what almost everybody is going to be doing, so I didn't cover what we'd be doing if we weren't. If you're in the 2017 transition phase, those are the measures that you're going to need to do. And again, if you don't report on a security risk assessment, if you don't do that, for instance, you get a 0. And just talking about security risk assessments a little bit, and I really wanted to call this out because CMS over and over in the federal rule talks about this. I would encourage people to get a formal risk assessment if you haven't already done so under the Meaningful Use program. It is something that will just help you stand up against an audit or have that process in place if you need to. So once you get through the bonus points, then you move on to performance points. So good performance gets you a higher score, basically. So the transition measures that are available can actually get you 90 percentage points. So you could score, your total score could be over 100% in this if you're performing well in it. What they do to get the performance score for the measures, each score is based on your performance from a 0 to 10, very similar to the quality. So quality, we had a 0 to 10, same exact concept. The little bit of difference is it's based totally on your performance. So in the example below, if you had a 75% on your performance, your numerator and denominator equaled 75%, then you earn 7.5 percentage points for that measure. And then those are all added up in addition to your 50 points that you already got from your base score. There are bonus points available for reporting to a public health registry. So if you're doing a specialized registry, there are potential bonus points. And also I mentioned earlier, and I'm going to talk about this more in the improvement activity webinar next week, but if you're doing certain improvement activities and utilizing your EHR system, there are bonus points available for that as well. We will dive into that a little bit more next week with some details, but it's just different ways that you can get some extra points if you're needing to score higher in this particular component. So this is just an example of how they get your total ACI score. Take your base score, your performance percentage points, your bonus percentage points, and give you a total score. And you can see in the example on the right, your base score of 50, your performance points, your bonus points, and then you have a total score of 81. So this table is a review of the measures. I wasn't going to dive into the details of the measures in today's webinar, but just wanted to give you a high level of what the measures are. Most of them should look very similar to what you might have seen in Meaningful Use. Security risk analysis, e-prescribing, patient access, view, download, or transmit, patient education, secure messaging, health information exchange, med reconciliation, immunization registry, syndromic surveillance, and specialized registry. So you can tell there's a focus on patient engagement as far as portals and secure messaging and education, and also on exchange of information. Those are the areas that CMS is really focusing on. So again, I just wanted to reiterate the importance of a couple of things. So the focus that CMS put on the security risk assessment was pretty significant. And I just wanted to kind of call out and say, these are something that we see often fails an audit in Meaningful Use, people that don't do their security risk assessments. The guideline requires that you've done a security risk assessment, that you have a remediation plan in place, and that you've resolved or at least outlined a resolution plan for the security gaps that you might find from your security risk assessment. The ACI component will be subject to audits just like Meaningful Use. So you want to have everything that you've done, all the components that you've put into place that you've attested to, make sure that you have backup documentation just like we did in Meaningful Use. And I think the most important thing is that the base measures are critical. Without them, you get a 0. You can't move forward. So you really want to pay attention to the base measures. Okay, so that's a review of the program. Let's just talk about what you should do to start. So don't get a 0 on your base measures. That's the important thing. If you want to review the details of the measures themselves, I put the website up here for the CMS measure review. So it's qpp.cms.gov. That's an important website for everybody to have. Schedule your security risk assessment. Make sure that e-prescribing is in place and that your providers are doing it. Of note, controlled e-prescribing is not required for this, so that's an important thing. I know a lot of people are working on controlled substance e-prescribing right now. It's not required as part of MIPS. Implement your patient portal or adjust your workflows if you already have it in place. And then develop a clear process for transferring information to other providers. This measure is not going to go away. I think it's going to become more important. So we have to really start working on transferring information to other providers about our patients. And identify measures which are going to get you the performance measures. So which ones have you performed well at in meaningful use in the past? So focus on low-hanging fruit, things like patient education and med reconciliation. Typically, I have seen those scored very high in meaningful use, so I think they're good ones for people to focus on. And also providing patient access. That's the patient portal. So you can control your workflow to make sure that everybody has access to that portal. Begin putting a focus on patient engagement with your patient. I think that's important. I think we really need to start paying attention to how we engage patients more with the portals. You know, we give them access, but there's really no work done on the portals. We don't do a lot of effort into them. So I think that's something we want to put some focus on. And then also identify any registries that you might want to participate in. This process can take a little bit of time. So if you think you want to go after a certified registry of some kind, make sure you know what it is. Engage with your vendors early, because that process can take 2-3 months sometimes to make it happen. Update your technology and workflows. If you want to work with your vendors, your internal technical staff, adjust anything in your EHR that you need to. Do you need to turn something on for your portal? Do you need to turn something for e-prescribing on? Just make sure that you have all of those things in place and that your vendors and your technical staff know what that is. Again, work on the patient portal piece of it. I think there is a lot of room for improvement here. We don't use secure messaging frequently in our practices. I think it's something that patients are expecting. You know, they work with their bank electronically. They do everything electronically. And I think that there's more of an expectation that they can communicate with their physicians electronically. So we need to start focusing on things like secure messaging. And also just maybe letting them know that they can get their test results on the portal. That's something that can drive them there. And then lastly, I think sometime in 2017, we are going to need to do an upgrade. Just work with your vendors, stay on top of the new timeline so that you know what's happening. Okay, so our next webinar will be next Wednesday at the same time, noon. This is the last one in this 4-part series that will focus on improvement activities. I do foresee after the first of the year that we may pick up some additional webinars with more information. However, this will be the final webinar in this particular series, just covering the program as a whole. Okay, so if you have any questions, you want a free financial calculator so that you know your impact, you need to schedule your security risk assessment, you want to just start engaging in the process, feel free to reach out to either me at health1tech.com or Joe Young at gds.com. And I will open up questions at this point.
Thanks, Jen. That's a lot of information there. So, what do you have any thoughts on the impact of the EHR landscape as MACRA is enforced and adhered to? In other words, do you think there's any possibility of existing EHRs possibly losing certification or and maybe forcing practices to look for alternatives?
That may happen. I don't think that's going to happen in the first 2 years of the macro program. I think that there will be, if people aren't able to meet the 2015 certification, I think that we'll see that. However, CMS has been really flexible with making up these rules and making sure people are engaged to things. So I think that even though they're saying right now we need the 2015 certification, I think there's a possibility that they'll extend that a little bit. With that said, I also think it's important that we stay on top of the certifications. You know, there's a lot of good stuff in these technologies as they upgrade. So I think as clients, we need to make sure we stay on top of our vendors as well to push for what we want.
Excellent, excellent. Well, I think you hit it out of the park because there aren't any more questions. So with that, I want to say thank you again to everybody who attended today. And the next webinar, the fourth in our series, will be next Wednesday at noontime, the fourth and final one for this webinar series, and we hope everyone can attend. So with that, thank you. Thank you, Jen, and look forward to next Wednesday.
Okay. Thanks, everybody. Have a great afternoon.